Hello everyone and welcome back. I hope you had a nice break and a good hands-on session. We will now start with our next lecture on the topic of the cardiovascular risk patient. Our next speaker is working at the cardiology department of the University clinic, and he's a specialist in echocardiography. He will now tell us a few facts about the cardiovascular risk patient and how ultrasound might be useful in diagnosing. Please welcome Dr. Ewald Kolesnik.
Thank you for the introducing words. Dear team of Sono for You, it is an honor for me and a pleasure for me to stand here and support your late summer school with the cardiovascular risk patient. This is the topic that I'm working on and that I'm going to present you, dear colleagues. When I prepared this presentation, I thought on what the content should be, because the cardiovascular risk patient is a huge topic. So I emailed a lot with the team of Sono for You, and they said, well, it's up to me. It would be nice to include some case reports. I thought this I can do. But including cardiovascular ultrasound, I thought, it's not my first choice, but I will try to do so. The next step I did was to go on the website, on the homepage of Sono for You, and they say that the learning objective is to that the learning objective is for participants to understand the indication and limitation of focused use of diagnostic ultrasound. And then I said, well, I kind of know what I want to present here, and then the idea of this presentation was born. My name is Ewald Kolesnik, and I am a resident here at the Cardiology Department of the Medical University of Graz. I want to perform a quiz during this presentation, so I do this via this menti.com. I don't know if everyone knows this platform. It's quite easy. You can either go to the URL menti.com and enter the number that's written here in red, so 9617958, or you go the modern way and just scan the QR code. You should be redirected to a website where question 1 should appear. So the quiz is not starting right now. The website will ask you to enter a name. You don't need to enter your name. It's just for a leaderboard at the end, because the one that gives the most correct answers and the fastest the correct answers will be named at the end of the last question. So I hope that a lot of us can participate, and I will ask the questions as soon as we come there. So the next thing was, when I took a look at the logo of the Late Summer School 2020, I noticed that here, this transducer, in my eyes, it's a phased array ultrasound transducer. Of course, the gastroenterologist will say, no, it's a curved array, and the angiologist will say it's, of course, a linear array ultrasound probe. But it reminded me on my ultrasound probe that I work a lot with, so I will start to tell you just a little bit on cardiovascular ultrasound, what it's good for and what we can do with it. So we can do a 2D analysis. We see here a classical parasternal long axis view, where we can see some cardiac chambers, like here, the left atrium, left ventricle. Here's the ascending aorta. Here is a part of a right ventricle. And what we can do here is to stop the image, to stop the video, that we get an image, and then we can easily measure some dimensions, like here in red, the interventricular septum, in green, the left ventricular diameter, and in blue, the posterior wall thickness, so we can quantify hypertrophy or non-hypertrophy, dilatation or non-dilatation. But echocardiography can do more. We can do the assessment of the left ventricular systolic function. How do we do this? We see here an apical 4-chamber view with focus on the left ventricle. And since we have an ECG reading, we can easily stop this video clip in end diastolic and end systolic position and just draw more or less an endomyocardial border and define thereby the area in end diastolic position and the area in end systolic position of the left ventricle. And then the ultrasound machine easily calculates here the so-called ejection fraction. It is 33% in this patient. And those of you who know how to interpret cardiovascular ultrasound or see this apical 4-chamber view here will say that it's not okay. And indeed, this is an image of a patient that's affected by heart failure. But ultrasound of the heart can do even more. We can go for Doppler analysis, so this is now very deep into cardiovascular ultrasound. We can measure blood flow velocities, a certain positions, like here on the left side, the transmitral flow into the assessment of the diastolic function. On the right side, we see a tissue Doppler with these colors, blue and red. So this is more or less how fast the myocardium moves in relaxation matters. So this is useful for the assessment of the diastolic function. And we can do even more. We can assess valvular heart disease by the use of color Doppler. Like in this case, we see here a blue flow. So it goes from, the blood flows here from the left ventricle back to the left atrium in systole. So this is more or less the view of a mitral regurgitation. And since we have a large jet here, we have a severe mitral regurgitation. By 2D analysis, we could go for the assessment of, for example, stenosis, like in this case, person on a long axis view on the left bottom side, and on the right bottom side, the person short axis, where we see that here, marked with red, that the aortic valve isn't opening properly. So this would be the view of an aortic stenosis. Image quality is not so optimal here, but this is real life. And in the end, we can do fancy stuff like strain analysis. So this is a computer-assisted software tool where more or less the so-called speckles. Speckles are these white dots here that form the myocardium. They are called speckles. And by the analysis of the whole portion of speckles in every segment, in their direction, for example, in the longitudinal direction, we can see a longitudinal shortening, and this is called strain. And we see here on the right side a strain pattern of an infarction of the anterior wall, where we see that dark red and lower numbers indicate us good contractility, while the bright fields and the higher numbers indicate a bad contractility, although strain is not really contractility, but let's call it like this. And we can go for 4D echocardiography, which we can see here for example, a full 4D volume calculation of single cardiac chambers. So ultrasound can do a lot. And is it really relevant in cardiology? The answer here is yes. We have the lucky situation in cardiology that we have a guideline for nearly everything. So, for example, we have the guidelines for acute and chronic heart failure, we have the guidelines for the chronic coronary syndromes, the guidelines for atrial fibrillation, the guidelines for patients presenting with chest pain and ST segment elevations and non-ST segment elevations, and the guidelines for the management of valvular heart diseases. And now I did the following. I just searched all the guidelines for the term echocardiography. And the results are the following. We see in every guideline the word echocardiography is mentioned multiple times, with the highest number of mentioning in the guidelines for heart failure and valvular heart disease. So indeed, echocardiography, we can say, is a quite useful tool in the diagnosis and treatment guidance of cardiovascular diseases. But how about cardiovascular risk? I want to remind you the topic of this presentation is the cardiovascular risk patient. And cardiovascular risk, we need to ask the World Health Organization, what is it defined? And they say that total cardiovascular disease risk is defined as the probability of an individual's experiencing a cardiovascular disease event over a given period of time. Or in other words, as I stand here in front of you, how likely is it that I, with my personal risk profile, experience a myocardial infarction within the next 10 years? This is of particular importance because we have to keep in mind that globally, cardiovascular diseases are the #1 cause of death, representing 31% of all deaths in the year 2016. And this has not changed until now. And what we also need to keep in mind is that most of these deaths occur in low and middle income countries. So it's mainly a problem of the third world. In Austria, in Europe, or let's call it the Western Hemisphere, we have access to good medication, we can treat cardiovascular diseases, and people don't die that often anymore from cardiovascular diseases. They still have a lot of burden, but it's mainly a problem of the third world to die from it, really. And at this point, I want to ask you the first question. So please go to your smartphones if you have internet access. We will switch now the presentation for those of you who have not scanned the QR code. You can do this right now. And here we go with the question 1, so you can all log in. And we can start with the first question, so just go in the next slide. So, wow, a lot of players are added. And then start the countdown, and I will read the question. So, the first question is, what do you think? What is the most cost-effective measure for cardiovascular disease prevention? Is it to stop smoking? Is it a good blood pressure control? Is it to lower blood lipids? Or should we say diabetes has more and more prevalence, so we should face diabetes and treat it properly? We wait for your votes. So thanks a lot. We have quite a lot of participants. Very good. 38, so the most of you say that stop smoking is the most important cost-effective measure. So we can go back to our presentation. It's simple why this is the case. We said that cardiovascular diseases or cardiovascular deaths occurs in low and middle income countries. They don't have access to blood pressure medication, they don't have access to lipid-lowering medication, they don't have access to aspirin and all the pillars that we need for prevention of cardiovascular diseases. So stop smoking is probably the easiest way to avoid it. And if we think this is a problem for third world countries, in Austria we have 20 to 25% of the population that is actively smoking a cigarette a day. So we still have a rather high prevalence for this here, and this would be the most cost-effective measure in order to prevent cardiovascular diseases. When we talk of the cardiovascular risk factors, we talk of risk factors for atherosclerosis. So let's say this is a blood vessel and it has a normal condition, a normal blood flow, and everyone who has such a blood vessel with smooth walls of the blood vessel is in a happy condition. But as risk factors occur, like arterial hypertension, active cigarette smoking, we see that the walls of the blood vessel start to thicken. The more risk factors we acquire, for example, high blood sugar, high cholesterol, adipositas, and lack of physical activity, plaques start to exist, the blood flow gets less, the patient gets more and more unhappy and will likely have more and more symptoms, and stress and genetic factors conclude this. And if the blood vessel has a severe obstruction, if this is a blood vessel that supports the heart with blood, then we call it coronary artery disease. So this is more or less atherosclerosis of the coronary arteries. And the problem is that if blood flow gets less, at a certain point it will stop, and then we have the full view of a myocardial infarction. We can see this, the patient will have severe chest pain. Everyone at the age of 50 should routinely get an echo. Echocardiography plays practically no role in cardiovascular risk assessment, or echocardiography significantly improves the cardiovascular risk assessment. So thank you for your votes. Interesting. The correct answer is the third one. Okay, I asked this question for a certain reason. You can switch back to the main presentation. You are not that wrong. You just, I think you just understood the question wrong. I asked for the cardiovascular risk assessment because what we stated before was echocardiography is quite useful in the diagnosis and treatment guidance of cardiovascular diseases. A patient or a person at cardiovascular risk doesn't have a cardiovascular disease. So these are two different topics. In order to identify the cardiovascular risk, we also have guidelines for this in cardiology. We have two, the 2016 guidelines on disease prevention in clinical practice and the 2019 guidelines on dyslipidemias and lipid management, which is more or less an updated version of the 2016 guidelines of disease prevention. And if we search now for the term echocardiography, we find 10 matches in the disease prevention guideline. This would support your answers for the last question, but only one match in the dyslipidemias guideline, which is more or less an updated version of the clinical practice guideline of disease prevention. And this one match can only be found in the literature section, so the whole guideline doesn't even mention echocardiography. And if we take a closer look to the 2016 guidelines, it has an own chapter for echocardiography. And as you can see here, this imaging tool is not recommended to improve cardiovascular risk prediction. Why is this the case? If you have asymptomatic patients, you wouldn't gain any benefit by doing an echo. Because if you find something, you would not know if it really increases the cardiovascular risk. So for example, a light gray or a mild hypertrophy of the myocardium, you would not know what to do with this result. And it's a logistical change because the whole population is at cardiovascular risk, as we said before, and this is really a problem for the whole population. We had to do an echo for everyone at a certain time point. And there are not enough ultrasound machines out there and not enough people who really know how to do an echo. Okay? So we have to say it's quite useless in the cardiovascular risk assessment, but it's not useless at all. And I want to show with the following 3 cases why this is the case. So we start with a daily routine. Let's say 8:35, after drinking our first coffee in the morning, the first patient comes in, and he's a 40-year-old man. He comes in a bad mood. He's nervous. He feels chest pain. He feels thirsty. And he says, well, there's an epicardial discomfort. So he won't say epicardial, but he says there's discomfort in this region here. We talk with him for 30 minutes and do some examinations. I will come to it afterwards. 30 minutes later, the second patient arrives. He's a 75-year-old man. And he complains about headache. He can't sleep the last weeks. He has insomnia. He says he has chest pain. He feels fatigued. And as we talk with him, we can find out he seems like a depressed man. Okay? We deal quite long with this patient, 50 minutes, because we had to do a little bit more with him. And then the third patient comes in. She's a 56-year-old woman. And she says, well, she feels dizziness, loss of appetite over the last month. She feels chest pain, has flatulences, and diffuse joint and muscle pain. And if we compare all the 3 patients, they have one thing in common. And this is chest pain. And this is a thing that occurs quite often in emergency departments or if a patient comes to a doctor, because chest pain is a symptom that occurs with many diseases, and we must differentiate if it's coming from the heart or if it's not coming from the heart. So we need to think of differential diagnoses. And my previous speaker, Dr. Lammer, already told you about this differential diagnosis. Of course, I will take a look on those differential diagnoses from a cardiology point of view. And as I said, cardiovascular diseases are a global burden and an important problem. This is something that I need to keep in mind. Is it an angina pectoris that's coming from the heart, and is it a coronary artery disease that causes this chest pain? Unfortunately, we have a lot of other cardiac diseases that cause chest pain. Most of them are more related in the acute situation, but nearly every cardiomyopathy goes in line with chest pain, secondary to, for example, anemia or aortic stenosis, dissection of the aorta, inflammatory diseases, or stress cardiomyopathy called Takotsubo. And on the other hand, we have non-anginal thoracic pain. Here we have the pulmonary organ system that can do chest pain, for example, a pulmonary embolism, a pleuritis, a pneumothorax. It can come from musculoskeletal problems, for example, inflammatory or degenerative diseases, a neuralgia or a trauma. And it could come from the gastrointestinal system, like a peptic ulcer, gastritis, gallbladder problems, pancreatitis. So at some point, we need to differentiate, is it coming from the heart or isn't it coming from the heart? So we need to go into a deeper assessment. And the first thing I want to focus on is that we need to ask, what is this chest pain like? So we have good questions and good answers. Not a good question is to ask for the quality. Because I say now, so these are the typical forms from cardiac chest pain, so coming from thoracic angina, coronary artery disease. Patients describe a pressure, a tightness, a heaviness, sometimes straining, constricting, or burning, and sometimes just a discomfort. So we cannot really differentiate according to the quality of the pain. But we do have the option to ask, when does it come? How long does it last? Typically for cardiac chest pain is that it's gone within 10 minutes and lasts longer than a few seconds, and it should be provocable on exertion and should recover totally at rest. And the third important thing is the location. Cardiac chest pain typically occurs in the chest, near the sternum, in the epigastric region, in the lower jaw, and between the shoulders, and in the arm or left arm, let's say. Okay? And the European Society of Cardiology gives us more or less types of anginal chest pain. They say it's typical angina if it meets 3 criteria, it's atypical angina if it meets only 2 criteria, and it's non-anginal chest pain if it meets only 1 or 0 of these criteria. And the criteria are the location, so as I said before, front of the chest, neck, jaw, shoulder, or arm. It should be provocable, and it should come to a recovery at rest or after the use of nitrates. If it only meets 2 of those criteria, we call it atypical angina, and if it's meeting only 1 or none of those criteria, we call it a non-anginal chest pain. So we have to ask our patients again, describe your symptoms. First patient says, well, it's a burning sensation. It's in the chest and the left shoulder. It radiates in the epigastric region. It occurs during work, at meetings. It comes and goes in minutes. He never tried nitro, and he's a busy man. He doesn't do sports. So from this here, I would say we have a typical location. It is provocable due to stressful situations, although it's not. So I don't think that it comes every time at work. He doesn't say that he has problems when walking upstairs or something like this, and this he will do. And the recovery is also not really related, the situation is over. So I think it is provocable. We have 2 criteria. We have an atypical angina here. Next patient, the 75-year-old man, tells us it's a pressure behind the breastbone. Sometimes it radiates to the chin. It comes during walking up the hills. He has to stop, then it goes away. Sometimes it occurs at rest as well, especially when he's watching the news. You know, all this corona stuff and lockdowns. He's old and doesn't come to the grocery so easily, so he's afraid of this. When he watches the corona news, he needs to use his nitro spray, then it's okay again. So here I think we have all features of typical angina: location, provocation, and recovery. And the third patient, this 56-year-old woman, she says it's a strange feeling. It's coming in the upper body part, in shoulder and backbone. She has to take some deep breath, then it goes away. It takes half an hour or so, and with exercise she's fine. So we only have a typical location, but it's not really provocable with exercise, and the recovery by taking some deep breath, it's no feature of typical angina, so this would be a classical case for non-anginal chest pain. What is this good for, this classification? We know that we can assess a pretest probability only by assessing the symptoms, saying it's typical, atypical, or non-anginal, and the age of the patient. And if we know the gender of the patient, then we know how probable is it that the person really has coronary artery disease. And we see here that we have this table, and in order to explain this table, we need to know that a detailed, in-depth testing and non-invasive testing is only recommended with persons that have a pretest probability of at least 5%. If the pretest probability is lower than 5%, we don't need to go for any further testing because that it is really coronary artery disease is very unlikely, despite you have an established risk profile or clearly cardiac symptoms. Then you could go for the tests anyway. So you need to individualize this. If you have the 30-year-old man with typical angina, it says it's not likely because we have here the 3% likelihood. But if this patient has type 1 diabetes for 30 years, then of course the situation changes. Okay? So let's take a look where we would put our patients. Our atypical angina patient, he's a 48-year-old man, has a pretest probability of 10%. The 75-year-old man has a pretest probability of 52%, and the woman has a pretest probability of only 3%. Of note here, a direct referral to an invasive testing is not recommended for anyone, despite you have compelling reasons, because we are afraid of complications due to heart catheterization. So we have bleeding complications and we have the stroke as a complication. We need to give contrast agent. We do have complications, and no one should get referred to a direct invasive strategy, testing strategy, if not diagnosed with a non-invasive testing. This says the guideline. And it's all about the clinical likelihood of coronary artery disease. This table, I must admit, is only valid in low-risk countries that are defined by the European Society of Cardiology. So you have low-risk regions and high-risk regions. More or less every country in the European Union is defined as low-risk, despite Far East countries. Let's say the Western Hemisphere is low-risk. But you can modify this risk. You have things that increase the likelihood of coronary artery disease and that decrease the likelihood of coronary artery disease. And one thing that decreases the coronary artery disease is performing a computer tomography of the heart and calculating the calcium score. If you have a calcium score of 0, then coronary artery disease is very, very unlikely, no matter how high the risk profile really is. On the other hand, if you have a patient that has symptoms, and all the 3 patients here have symptoms, you should go for things that increase the likelihood. These are risk factors, a resting ECG, where we see changes according to coronary artery disease, like Q waves or ST segment changes. And here they also say left ventricular dysfunction. So at this point, with a symptomatic patient, an echocardiography is recommended, but not for the asymptomatic patient. And then, if we have assessed comorbidities, ECG, and transthoracic echocardiogram, then we could think of additional further testing. And there are several additional further testing methods, and it's not so easy to say, well, this is the optimal test for this patient, and I would send this one to the coronary CT and this one to the scintigraphy. What should I do? Well, there's an easy rule. The guidelines suggest that we should go for a stress imaging test if we have a high likelihood or high pretest probability, or a CT angiography of the heart. Okay? We do have the stress ECG, although the stress ECG is not really recommended, because we see here the red bar indicates the true positive. So everyone that shows a pathological stress ECG has more or less a significant coronary artery disease, but you cannot exclude it with a negative stress echocardiography. If you don't see any changes, it's not good for an exclusion. So that's why we do not perform these tests, so that we do not like to perform these tests in order to diagnose a significant coronary artery disease, although you can use it as a risk modifier. Better, so you are with a stress ECG, you are unable to rule coronary artery disease out. Better to rule coronary artery disease out is to go for a cardiac CT angiography. Because there you see if you have calcifications, if you have an obstruction, or if you don't have calcifications. So for all patients where I think, I don't believe you have a significant coronary artery disease, but you have symptoms and you have a low pretest probability, send him to the CT angiography. Okay? The old patient that has multiple risk factors will get a positive coronary CTA where I don't know if it's really significant. And for those patients where you think, well, I believe that this one has a coronary artery disease and I want to prove it, then go at best case for the SPECT, for the scintigraphy. Okay? Because here you have a rather high chance to get a positive result for ruling the patient in coronary artery disease, but you have also a great chance to rule him out without an overlapping zone. Okay? So these are my recommendations. And what is now the best testing method for which patient? First of all, we said we must go for the comorbidities. First patient says he's an active smoker. He has a positive familial history. His father had a myocardial infarction, and he himself had a peptic ulcer some years ago. This also might cause his chest pain, we have to keep in mind. Second patient says he has elevated blood lipid levels, he has a type 2 diabetes mellitus, he has a COPD, but he stopped smoking some 15 years ago and it's stable, and he feels intermittent claudication while he's walking. Third patient only says she has hypothyroidism and an osteoporosis. Okay? Since all patients report symptoms, everyone should get an ECG and a transthoracic echocardiogram as stated before. So let's take a look at the first patient. He says he's atypical angina, he has a pretest probability of 10%, he has an established cardiovascular risk profile with active smoking. Let's take a look at his ECG. You see here, this is a normal sinus rhythm in the lead 1, you see clearly P waves. You have narrow QRS complexes. You have no ST segment elevations and depressions, normal heart rate. But you see the T wave here is quite with low voltage in 1, in AVL, and in V6. Okay? So if I take a look on this ECG, I would say it's not really abnormal, but it's also not really normal. This is always difficult. Let's say it's somewhat a normal ECG. Okay? The next thing we do is we go for the echo. And in the echo, we see an apical 4-chamber view. The perfectionists of you will recognize here of the anterior mitral leaflet. There's a small prolapse, but it doesn't cause a regurgitation. With a good left ventricular function, we have no evidence of hypertrophy. We have a normal echo. Okay? So my question to you comes the next. Please enter your smartphones again. What should we do with this patient? This will be the next question. What would you do? You can press enter. Yes, thank you. So what is the probably best next step? Symptoms, pretest probability 10%, risk profile, normal echo and ECG. Nothing. We go for no further testing. We need to rule out coronary artery disease, go for cardiac CTA. We need to show significant coronary artery disease, go for scintigraphy, and don't give anything about what I said, go for catheterization. Very good, very good. Thank you. So, this is the optimal choice for this patient. If I see him and look at his profile, I would say, well, I don't really believe that this 48-year-old man needs a stent. So I would say we should examine him in depth, but I want to rule out coronary artery disease, so send him to the computer tomography, ideally combined with an angiography. Patient 2, so we refer him to the CT. Patient 2, we need to work him up. He has a pretest probability of 52% and established risk profile. If we take a look at this ECG here, we see again a normal sinus rhythm. Here in lead 1, we see P waves. We see again narrow QRS complexes. ST segments, well, you could say V3 to V5, it's somewhat depressed, but not consistently. So it's not convincing me, this ST segment depression, but it's not normal because we have a left axis deviation. We see here the leads 2 and 3, they are quite negative, and AVF2. And we see Q waves in 2, 3, and AVF. So this looks a little bit like a chronic myocardial infarction of the inferior wall. It's clearly not a normal ECG, it's an abnormal ECG. We do the echo. We see here an apical 2-chamber view. We say overall good contractility. I think the left ventricular ejection fraction would be around 50%. But if we take a closer look, then we see, experienced cardiologists would see it, here at the inferior wall, there's a hypokinesia. Okay, so this section here is not contractiling as well as the opposite side here. Okay, so we have an abnormal echo too. And this is where my third question or fourth question starts. So please go again. It's the same question as before with the same choices. In this patient, what do you think would be the best next testing strategy? again, we send him to nothing, no further testing. We send him to the coronary CTA. We send him to the SPECT scintigraphy, or no, we say go directly to the catheterization. Okay, very well. Thank you. Most of you did the absolute correct thing. Okay? If we say that the patient has no symptoms at rest, he will have coronary artery disease. I'm convinced from it. But if we refer him to an invasive testing, then the cardiologist will probably say, well, without non-invasive testing, I won't touch anything. Okay? If he's stable, if he has no symptoms at rest, he has stable angina pectoris, so we need to, firstly, according to guidelines, we should examine him in death to rule him in. Maybe some cardiology departments would go for a direct invasive strategy, but it's not recommended in this constellation. So I would send him to a SPECT, to a scintigraphy. Third patient, let's take a look at her workup. We have a low pretest probability, we have no risk profile. Here's the ECG. We see again a normal sinus rhythm, P waves in the lead 2. We see narrow QRS complexes. We see no ST segment depression or elevation. And we see normal shaped T waves. So this is truly a normal ECG. When we take a look at her echo, we see she has a good left ventricular function, normal left ventricular ejection fraction. Maybe here the interventricular septum looks a little bit like mild hypertrophic, but nothing more. So I would consider this echo as normal too. Now, what are we going to do with her? I ask you once again and one last time to answer the question, and then we will have a winner at the end here. It's the same question as before. So, what are we going to do with her? What is the probably best next step? Nothing, no further testing needed. We need to rule out coronary artery disease, computer tomography, no sensitive SPECT anyway, or I don't believe in anything, I want that she gets a catheterization of the heart. Very well. So please go to the next slide and not change the presentation because we do have a winner. And the winner is, well, it's very close. Now it's time dependent. And Puggy is on the top, or it's a tie. Okay, so all of you should become cardiologists at one day. Awesome job. So let's switch back to our presentation, and thanks for participating. Okay, yes, that's true. We are allowed to say, stop it at this point. A further testing is just giving us not more information. We did an ECG, we did an echo, everything is normal. We don't really need to go for a coronary, for a CT scan of the heart. So do we just say goodbye? No, we should go for primary preventive strategy if we see her and she presents with her symptoms. How does primary prevention work? We need to assess the smoking status, we need to get the blood pressure, and we need to assess the cholesterol levels. So in this case, she has a blood pressure of 130 millimeters mercury, a total cholesterol of, let's say, 280 milligram per deciliter, which is quite high. Then we have these charts. Maybe you know them. These are the primary prevention charts valid for the low-risk regions of Europe. So also here are differentiated between different countries. And here we see we have the age, we have smoking status, and we have the gender. And if we add all the values here, we see that she has a risk of this square, and this square means 2%. She has, with her constellation, a risk of 2% of dying from a cardiovascular event within the next 10 years. And multiplied with the factor 4, she has a risk for any cardiovascular event within the next 10 years of 8%. Okay? This is called moderate risk, and the main driver is age here. in her case, cholesterol, of course, too. So what we need to ask ourselves is, what would be the best cholesterol? Does she need a statin or doesn't she need a statin as a medication? And here we get help from this next chart. And here we see on the left side, which is her risk class level with 2%. She's in this level here. The next thing we need is the LDL cholesterol levels. We see that we measured 150 milligrams per deciliter, which is quite elevated. Then we say she has a risk of 2%. This is her score risk value. And with her LDL of 150, she's up in this region here. And the recommendation is then to go for a lifestyle intervention, and we should consider adding a drug, adding a statin, if the cholesterol is not controlled due to lifestyle measures. Okay? So she would be a candidate for a statin. Let's go back to our patient 1. Here's atypical angina and comes back with its coronary CTA scan. The radiologist says we have 3 calcified plaques in the LAD. We see them as those white spots here. And he unfortunately also tells us we have a total coronary calcium of 307, which is significantly elevated. He has symptoms. We cannot exclude coronary artery disease with the CT scan, so we should go for an invasive testing strategy with him as well. And he is then referred to the next cath lab. In the cath lab, we see here the right coronary artery. We see a normal blood flow in the right coronary artery. And we see the left coronary system, and here we see a quite fine blood flow too. I will stop those images, or those video clips, in order to see the images. And then we see right side no obstruction, left side no obstruction. What now? Just say goodbye to him now? No. If we take a closer look, then we see that the coronary arteries are not healthy at all. They have plaques here in this region of the left anterior descending artery, which are described in the coronary CT scan 2. And we must avoid an upcoming cardiac event, an upcoming myocardial infarction. This is not suitable for stenting. We shouldn't revascularize it. But this patient will probably profit from secondary preventive measures. We should animate him to stop smoking. He will profit from a statin therapy, so he should get his preventive strategy as well. And he will likely profit from an aspirin as well, because we have an established coronary sclerosis without a significant obstruction. So this is a patient that should be treated medically in order to avoid a myocardial infarction. Patient 3 comes back with his SPECT result, and we see here these black zones here, they are not good. They mean perfusion defect. And the nuclear medicine specialist says we have a large cardiac perfusion defect with small zone of reversibility in the territory of the right coronary artery, which fits rather well with our suspected inferior infarction that is old. So he also got his ticket for the invasive testing strategy. And let's take a final look on his coronary arteries. We see here the right coronary artery, and we see here that we have nearly a total occlusion, a subtotal occlusion. We see contrast in the right coronary artery until the end. It is perfused, but this, of course, produces symptoms for the patient. The left side looks fine, the left coronary system. So what we should do as next step is to find out, or say, yes, this is useful for revascularization. The next step is to find out where is the culprit lesion, and it's here easy to say the right coronary artery. We put in this position of the stenosis a balloon, expand the balloon, put a stent there, expand the stent there, and the result looks like this. We have a fully restored blood flow of the right coronary artery, and hopefully the symptoms disappear for this patient. And he as well needs aspirin. He as well needs clopidogrel for 6 months at least. He needs a statin. He needs low LDL levels. And he needs a good blood pressure control. So this is all on top of this catheterization. So before I come to the end, I want to once again repeat the pillars for prevention. Think of lifestyle modifications. Think of active smoking. This is really a problem also in the year 2020. Aspirin is useful in secondary prevention only with established coronary artery disease, because if you give it in primary prevention without established coronary artery disease, you will avoid myocardial infarctions, but on the cost of gastrointestinal bleedings. It's the same amount. It's not recommended for everyone, only for those who have coronary artery disease. Statin use, we can calculate each statin goal according to the SCORE system, which I gave you a short overview on, and the rest of the cardiovascular risk profile. So think of this, give the patient a statin if necessary. Of course, we should think on blood pressure control and screen for diabetes. The prevalence of diabetes is increasing and is expected to increase more over the next decades. And in order to give you a short summary on how to deal with a patient at cardiovascular risk, we should consider doing the 4 steps here. Assess the symptoms and clinical presentation. What type of angina is it? The second step is assess the comorbidities and pretest probability for coronary artery disease. Think of differential diagnosis that it's not coronary artery disease that causes the chest pain. The next step would be the clinical workup. Here you should go for an ECG, for an echo for everyone that has symptoms, and what I didn't mention are biomarkers. They are also quite helpful. And the last step is to assess the appropriate further testing method. And here we should keep in mind, we have test strategies that are able to rule out coronary artery disease and that are able to confirm our suspected diagnosis. So thank you for your participation in this quiz, and if you have any further questions, I'm happy to answer them.
Well, thank you very much for your interesting lecture. Are there any more questions? Are there any questions from online? All right. Then thank you very much for your interesting lecture.
Thank you. Thank you.
And it's awesome.
Nice of you. Working on my diabetes.
So that was our late summer school for today. We hope you enjoyed it. Tomorrow we will start with the hands-on sessions in the morning again. Please arrive 30 minutes later than today. And we ask you to bring a pair of sport shorts, because we will perform an examination of your veins on the legs. Thank you.